Okay, so we're about to start our questions and answers session. And I see that many questions are coming in. Okay, without further ado, I would like to welcome Dr. Howard Schubiner. Dr. Schubiner is the founder and director of the Mind-Body Medicine program in Providence Hospital. He was included 3 times in the list of best doctors in America. Dr. Schubiner is a board certified in pediatrics, adolescent medicine, and internal medicine. He was a full professor at Wayne State University for 18 years and now works at Providence Hospital in Southfield, Michigan. He is a fellow in the American College of Physicians, the American Academy of Pediatrics, and the Society of Adolescent Medicine. He is the author of the books Unlearn Your Pain. Yeah. Unlearn Your Anxiety and Depression. Yeah. And a co-author of the great book Hidden Review. I don't have it right now. That he co-authored with Dr. Alan Abbas. Dr. Schubiner was the medical advisor in the Boulder study, which we just saw. And he gives lectures and workshops about mind-body medicine all over the world. You can also view Dr. Schubiner's work in the fantastic movie This Might Hurt, that explores his work. Dr. Schubiner, thank you for being us here today.
Thank you. You're very kind, Yoav. There was way more introduction than necessary.
I know.
Very kind. Thank you very much.
I think it's the second or third time I introduce you, and I keep adding a few sentences here and there.
We might need to subtract something in the future.
Right. Next time. Okay, next we have Dr. Yoni Ashar. Hi, Yoni. Yes, Yoni is here with us.
Hello.
So Yoni Ashar is a PhD and assistant professor at University of Colorado, Anschutz Medical Campus. He completed his doctorate in clinical psychology and neuroscience at the University of Colorado in Boulder, and an NIH-funded postdoctoral fellowship at Weill Cornell Medicine. Yoni's research uses functional MRI, brain imaging, as we saw in the movie, natural language processing, NLP, for those who know a bit about machine learning, and other clinical and computational tools to understand how mind and brain processes influence health, especially chronic pain. A main research focus is investigating a new class of psychological and neuroscience-based treatment, like pain reprocessing therapy, aiming for recovery from chronic pain. Yoni, Toda. It's nice.
Thank you. Toda rabba. It's great to be here.
Yeah. A bit of an Israeli connection in the background. As you saw, maybe
eventually smiling.
Yeah, as you saw in the movie with the Abba picture, right? Okay. So we have many questions for everybody, for Howard, for Yoni, and Mitch. Let me start with the following, okay? First of all, yeah, just a second because there's a lot. Okay. The first question, when I originally sent the invitation for everybody, I asked if you have a prior question before watching the movie, and the first question was for Laurie, because Laurie's introduction was she was a neuroscience. Yes, I can raise my voice a bit. She was first a neuroscience researcher and now a podcaster, filmmaker. So people were wondering about this transition and how it came about. So Laurie, if you can share with us, that would be great.
Sure. Wow, first question. Okay, let's jump into, I mean, I feel like I need to back up and tell you a lot of story, but I'll try not to take too much time. Yeah, so I actually met Yoni 10 years ago in Israel.
In Israel, in Jerusalem.
In Jerusalem. And flash forward however many years from that.
Hey, come on, you got a little more than that. More of the story. Laurie was my camper. Laurie was my camper on the summer program. She was like 16-ish. I was, I don't know, 20 something. So.
That sounds right. That sounds right. Yep. And flash forward to my professional life. I was working for a neurotech company in Chicago. And investigating the brain's interpretation of videos in the form of advertisements, and was finding it to be a little bit soul-sucking, and wanted to change what I was doing, and got in touch with Yoni, who had posted on Facebook about this study. And we got to talking, and I told him about my dual interest in video and film, and also neuroscience, and how what I was doing was not the ideal combination of those things. And he said, well, why don't you come out to CU and help me with this Boulder back pain study and work in the lab with Tor and I. And oh, by the way, you might want to get in touch with Mich, who is like trying to make a film about the study as well. And so it became this like perfect combination for me to just move my life from Chicago to Colorado and see what happened. And what happened is I worked on the study for a few years. I helped run the brain scans in the study, and I worked under Yoni and Tor. And then the lab moved to Dartmouth, and I had to make a decision about whether or not I was going to move with the lab and continue kind of in the film industry here, which I had at that point started becoming really entrenched with. So I remember the moment when I told Tor in his office, like pretty crystal clear, and I said, I think I'm gonna like make movies and not, move with the lab to Dartmouth, which I still think he's chewing on that. I'm not sure he understands the choice. Maybe neither does Mich or any of the filmmakers. No, I have since kind of transitioned into to storytelling. In the last few years, I've been working on science stories, but also other stories in podcast and film. So that's been my transition through the study, and kind of played this role as what Mich calls the spy in between the filmmakers and the study this kind of whole time, as kind of the linchpin between the two.
Okay, it's very interesting to see how the dots are connected. Staying with Mich, another question is, why on earth do a movie about chronic pain? When I think the question is, I have presented you with your very rich work, and all of a sudden a documentary about chronic pain. So where did that come from? Can you share with us?
Yeah, I like to do movies about things I'm not interested in, or things that come my way by different. I'm just kidding. I was approached by Alan Gordon. He got my name because he reached out to a director in Los Angeles that I had worked with who was suffering from chronic pain. I think the project was too close to him to do it. A lot of times films like this, the filmmaker will be in the film. I think we've seen films like that, or, they become a part of the story. Me having some distance but experience with film and making films about things that I'm not an expert in, I kind of go in a little bit open, but that's why we had the spy and Laurie to kind of make some of the neuroscience make sense. But then, on a personal note, my wife has suffered from chronic pain for 30 years and has had multiple back surgeries. And it was a way, I like the science angle, the study angle. It was an interesting, I've done films where journalists frame things. This was interesting to have scientists and the study as like the backbone of the film, which originally was a short, then it became a feature. Now it's somewhere in between. So yeah, I think I got into it because of the subject matter, the referral, my wife, the collaborators. And then when we did that first interview with Yoni, Dr. Knight, Tor, and Alan, we immediately kind of looked at each other. It was supposed to be over in like 6 months, and here we are 7 years later doing our first big screening. We knew we had something bigger than just a short film on our hand.
Okay, great. Thank you for that. So Dr. Schubiner, the next question is, I think, is for you. We get a lot of questions about fibromyalgia and CRPS. So people are asked, are there any specific protocols? Does pain reprocessing therapy works for these types of conditions?
Yeah, thank you. Thanks everybody for being here. It's really like an honor for me. I love talking in Israel. Never been there, but I love talking to people in Israel. I'm sure I'll get there soon. When we do these assessments, and that's part of what I did for the study, was trying to determine if someone's back pain was due to a structural condition in their body, some damage, some injury, or was it due to neural circuits in their brain, or a combination of the two. Most chronic pain is due to neural circuits in the brain. And we just finished a study of 220 consecutive people with chronic neck and back pain, where we determined, this study hasn't been published yet, as Yoni knows, but we determined that 88% of those folks had non-structural back pain. So when you have a non-structural condition, when you have a neuroplastic condition, we treat it using our model, our integrated model that includes PRT and a few other things as well. But the treatment is basically the same, whether it's fibromyalgia, where there's no damage in the body, or CRPS, where there's no damage in the body, or back pain, where there's no damage in the body, or irritable bowel syndrome, or tension headaches, or migraine headaches, or pelvic floor dysfunction, or need I go on? So it's real. There's no, people always want to know, like, well, how do I treat this disorder? But we're looking for the root cause of the disorder, right? And if the root cause of the disorder is in neural circuits in the brain, if it's an overactive danger alarm mechanism, then that's what we want to treat. And the manifestation of it can be anxiety or insomnia or fatigue or pain. That doesn't really matter.
Okay. A follow-up question that I see just returning in from few people. What happens when somatic tracking goes wrong? I think what they mean is what happens when we do somatic tracking, and you can even elaborate for those who are not familiar with this type of technique. And instead of the pain being improved, it's getting worse. Yeah.
Is Yoni, are you going to answer that, or?
No, you are.
Oh, I am. Okay.
I was not.
Well, when you do somatic tracking, when you do anything, you know, and the pain goes up, what does that tell us? You know, you're just watching the pain, right? You're just paying attention to it, and the pain goes up. What does that tell us? That tells us it's the brain. So it doesn't mean anything went wrong. It's not a failure of somatic tracking. It's more information. It's more evidence. It's telling us, as you're paying attention to it, your brain is getting more tuned into it. Your brain is getting more afraid or fearful or whatever's happening in the subconscious part of our brain that controls the pain. And it went up. Fine. You can still watch it. You can still use the model and use lots of other techniques. Somatic tracking isn't the only technique that we use, but it's scary for people when their pain goes up, right? And so what we want to do again is look to the underlying cause. The underlying cause is fearfulness in the brain. So that's what we're going to address. And so we've got a lot of techniques for that. And of course, if the pain's going very high, you're going to have to back off of what you're doing. You're going to have to calm the brain and lower the danger signal temporarily. But then you want to go back to paying attention to it, because over time, the brain will learn. What we're doing is we're training the brain. You know, we don't have a switch that we can flip on and off. We have to train the brain to lower the danger signal over time. And sometimes it takes more than a few days or more than a few weeks or more than a few months even.
Okay, thank you. Thank you, Dr. Schubiner. The next question is for Yoni. And the question refers to a certain scene in the movie where Alan, Dr. Knight, and you are sitting, and you can feel the tension, so to speak. Did you find it also during the study that, I mean, it's supposed to be a teamwork. It looks like a teamwork. You have Dr. Schubiner, who is a physician. You have Ellen Gordon, who is a psychotherapist, a researcher. Did this type of tension that I think deliberately was presented, I mean, Mitch could have cut it out, but I think it was deliberately, Mitch, you can elaborate later. Did you felt it during the experiment, during the process of the Boulder study?
Yeah, thanks for that question. And before I answer it, I just want to also just say a huge thank you and gratitude to Laurie and to Mitch and to Tim, the third director, who couldn't be here. This film was such a big hustle and push over years of effort. And there's so much that, for me, being involved in documentary is so much work than I ever imagined. And so getting it to this moment, to a public screening around the world, all these people here, just fantastic. And thank you to Yoav for organizing this. Yeah, that tension in that scene is a real tension that I continue to wrestle with which for me, as I think about it, is, how can you be sure that it is 100% neuroplastic? Is there not potentially some, isn't chronic pain always complex, always a combination of things going on in the body, the way the brain's, interpreting the sensations, where Alan would, like in the film and in real life, as we know, Alan is really confident to go in there and say, this is your brain, that's it, that's the cause of the pain. And, physicians like Karen and others tend to be more kind of holistic or considering other factors. And I think it's a bit of an open question. And my struggle is that on one hand, I really want to be honest and truthful and accurate to people. And I can see a lot of therapeutic value in just the clarity of telling someone the pain's caused by the overactive alarm system in your brain. And let's just be very clear about that. And maybe that's a bit of a simplification in some cases, or maybe it's completely true in some cases. And the ground truth is very difficult to know, because what do we really know for sure in the total, certainty? But I think that can be really helpful for some people to hear. And then for some people, it's very invalidating, and maybe there is something going on in the body, and the brain is the predominant cause, but there's, finally, I'll just say the split between the brain and the body is a problem, because we know it's all interconnected, and you feel stress in your brain and that causes muscle tension, and the muscle tension will send signals up to the brain. So it all kind of cycles, it's all interconnected.
Great, thank you.
On the other hand,
Please. I was hoping Howard would reply.
On the other hand, Alan and I are very simpatico in our approach. And Alan, for this study, Alan had the backup, so to speak, of me evaluating all the people in the study and using my medical acumen. And I consider myself an extremely conservative doctor. The last thing I ever want to do is tell somebody they have a mind-body problem or a neuroplastic problem, when in fact they have a structural problem. That's the last thing I would ever want to do. And I remember we had this party that was really an incredible party when we revealed the results of the study out in Boulder. And Yoni remembers it well, and Mich
Great night
there, of course. It was amazing. But anyway, and Dr. Knight was there. And before we revealed the results, I was talking with her a little bit, and she was asking this question. She said, well, how can you be sure? How can you know when someone's back pain is actually due to their brain? And, it was at a party. I didn't have time to spend a long time and talk with her, but I said, well, if somebody goes on vacation and their back pain completely disappears, and they come back to work and their back pain completely comes back with a vengeance, that would be a sign. And she said, well, maybe they're using different muscles when they're on vacation. And I said, okay, maybe. And then I didn't want to get into it with her, but that's the source of this tension, that you're seeing in the film, where she was holding fast to an idea that pain can never be purely due to the brain. And that's impossible to be true, because we know there are many disorders in medicine that are purely due to the brain. Psychogenic seizures or paroxysmal non-epileptic attacks, conversion disorders. There's just tons of other things like that we've seen, contagious disorders, right, that are socially contagious. So we know that the brain can cause a whole variety of significant and even severe symptoms in the body that are real, but again, caused purely by the brain. And so if the brain can certainly do that, it can certainly cause pain. And the proof is in the pudding. When 75% of the people treated had no pain after 1 month, I mean, that wasn't because that they had some lingering damage in their body that they were just ignoring, because the results stood for a year. And Yoni's doing a 5-year planning to do a 5-year follow-up now of these folks.
Yeah, that data is actually coming in right now, like this week. So,
really, as we speak, if they answer their surveys.
Probably you're like surprised, and you will share a screen with a date. No, it's okay. Okay.
I wish. If I had the screen ready, I would share it, but I don't.
We gotta cut this short and start filming again so we can get the 5-year recap in
Yeah.
here.
Get it in there. Okay, so I have a note from one member of the audience who says,
Yoav, if you can hold the microphone to your mouth, we can
yeah,
read
yeah,
it.
now it's better.
It's much better.
Great, thank you for that. So a note from one of our participants here. I found most of my patients aren't afraid from the pain. They know it's not harmful, but they just don't want to feel it. So how do you manage it? I think this question is for Yoni.
Yeah, I'd love to take that one and then see what Howard wants to say too. I have a bit moved away from talking about fear of pain to talking about the threat response or threat appraisal, because some people, the word fear makes sense. Other people, they're not afraid necessarily, but they just don't want it, like in that question, meaning the pain is a threat. It's a bad thing, it's a problem. And maybe it's more they're angry at it, or they're annoyed at it, or they're sad about it. And it's not necessarily fear, but anything that we can lump into the threat category. So I start, almost every clinical, at the beginning of almost every time I'm working with a client, I take out a whiteboard and I draw the pain threat cycle, where pain is perceived as a threat drives more pain drives more threat, and that's it. So I used to draw that with the word fear, but I had exactly this issue that the questioner is raising. People, I'm not afraid. Yes, but are you okay with it? Is it, are you totally fine with it? Or are you there's some way in which it's a threat to you? And then the goal of treatment is to eliminate that threat response. Like, it's not a threat.
Yeah, I would say that I've replaced fear with 6 F's in my practice. So it may be, for some people, it's fear of the pain. For some people, it's focus on the pain, paying attention, monitoring. For some people, it's frustration with it, resentment of it, anger with it. They just don't want it. And for other people, it's fighting the pain, giving it power over you. For other people, it's trying to figure it out endlessly. And finally, it's trying to fix it. And I've never had a patient who didn't say, I do a lot of those things, right? Because these are the natural responses people have to pain. And these 6 F's are the fuel that drives the pain. In addition, there's other ways of thinking about it. What if the pain is a message? I saw a woman this week who had burning pain in her feet. Okay, burning pain in her feet. What does burning tend to symbolize? What emotion is likely to go with burning, right? Anger, resentment. And I said, there may be some things in your life you can't stand. Your feet are burning. What are some of the things in your life that you maybe can't stand? And she identified several. And it was immediately clear to her that there was feelings in her, there was stuff going on in her life that was fueling this pain. And we needed to deal with that as well as doing the pain reprocessing work. So it's, there's multiple ways to think about this as we look at people, holistically.
Yeah, and I just want to comment, because this holistic approach is many times isn't the way the medical model works. I'm a therapist in a pain clinic where the clinic is actually making more money from injections than my hourly rate or whatever. So how do you combine it? How do you make the difference? Mitch and Yoni and everybody, you make such a great movie. You spread the knowledge, but still the economic, let's say, boundary is very, very hard to overcome. Any thoughts about that, Yoni, Howard, and Mitch and Laurie? Yeah.
I think it's a challenge. I'll say I wish I knew more about the economics of the situation. I know that, the problem is that the incentives aren't always aligned between the patient, the providers, and the payers. There is a move toward value. I think it's called value-based care, where you're paying for, more on the outcomes than on services provided. And I'm hopeful that might be part of it. But maybe Howard's been more embedded in the medical world, maybe as a perspective on what's going to take this to really make the economics work.
I mean, I just spent 20 years working in this field, and I've been talking to people at length taking lengthy visits, listening to people, validating them, loving them, helping them get out of pain for 20 years. And my hospital put up with that for 20 years, even though I was losing money the whole time. And then this past year, the hospital was in budget crisis and they decided they couldn't afford me anymore. So they got rid of me. That's the reality of US medicine that's driven by money. And when they got rid of me, my back started to hurt. And I had a lot of feelings about that, and I had to process those feelings to get rid of that back pain. And I'm in the process of writing an article about how the incentives are completely upside down. If most people who have a very large bulging disc in their back who need surgery, would benefit from surgery, can do with a foraminotomy that can be reimbursed, $5,000 or $8,000. But if the surgeon does a 1 or 2 or 3 level fusion and puts in 4 or 6 or 4 or 8 or 12 screws, now they're making $20,000 or $40,000 or $80,000 in the US healthcare system. It's hard. That incentive is very real and very powerful. And the incentive is driving tremendous amount of unnecessary back surgeries, unnecessary back injections that have not been shown to be better than placebo. So, my back's starting to hurt just talking about this.
Yeah.
Just
Yeah, it's not, you're not using your different muscles right now or something.
Exactly.
We recommend a great movie about this.
Yeah, exactly.
But I'll just add real quick, you process, and this whole thing is a process. Here we are 3 years after a lot of the filming's been done. One of the last shoots we did was with United Healthcare Group, who's the largest insurer, in the United States. And I think they were going to try it. We were going to put it in the film and it didn't really work. So there's a lot of things that end up on the cutting room floor that don't happen, that don't work, but it's these kind of conversations and having people like Yoni and Howard and yourself that are driving the dialogue forward, because it will take a long time for Alan's paradigm shift, I would say.
Yeah. Okay. That's a great comment. Okay. So next question. I'm sorry, guys. I won't be able to, I'm being bombarded here with questions on my WhatsApp and chat and all over. So I will try my best. I think this question is also for Howard or Yoni. What's the role of treating myofascial pain with dry needling in PRT? What about mixed condition with radicular neuropathic pain and pain influenced by stress and emotional condition and past learning? Okay, yeah.
Well, it's kind of a complex question. One of the things that I like to explain to people is what are the components of a placebo effect. And if you have a mind-body condition or a neuroplastic condition, you only need a good placebo, because the placebo is a powerful mechanism of changing the neural circuits in the brain. And I consider myself, and people disagree with me, people in our own community get mad at me when I say this, but I consider myself in many ways a placebo doctor. I help people harness the power of their own brain.
I always knew you were a fake, Howard. No.
Exactly. So, but the placebo effect consists of having an explanation for the problem, having a technique or treatment that addresses that explanation, having a caring and trusted provider, and having hope and optimism. In our case, we say, and we of course believe it's absolutely the truth, that the pain is due to neural circuits in the brain, or the fatigue or insomnia or anxiety, depression, whatever it is due to neural circuits in the brain. These are reversible. There's the hope. You have a caring practitioner, and you have techniques, PRT, emotional awareness, changing your life. There's a lot of techniques that we have, right? So that's what we do. So when you think about dry needling, for example, what do you have there? You have an explanation. Oh, the muscles are tight. They need relaxing. Here's a technique that can be helpful for that. Here's a practitioner who's caring and trusted, and there's hope for reversal. So dry needling can be a very effective method for neuroplastic conditions like myofascial pain because of the placebo effect. Physical therapy, Reiki, massage, regular acupuncture. There's tremendous amount of techniques that people have used that have been very effective for neuroplastic technique, for neuroplastic pain and other conditions, due to the power of people's brain to turn off their danger signal by feeling safer, by feeling in control. So that's kind of how I look at it.
Yeah, and the placebo effect is real.
It's very real. And it may be the muscles are tight. There's no question about it. The brain can make the muscles tight. Lorimer Moseley did a great study in Australia where he looked at the muscle tension and pain in people's backs. And there's evidence, sometimes there's muscle tension and there's pain, or there's muscle tension and there's no pain, or there's pain but no muscle tension. So not all pain is due to not all myofascial pain is due to muscle tension. Don't be confused about that.
So Moseley Butler issued the Explain Pain book, and was translated into Hebrew. Very, very highly recommended. Yoni, yeah.
I'd love to add one thing. I love Howard's response on the subject of placebo. So there was another arm in the study that didn't make it into the film we just watched. It was called an open label placebo arm. This is actually the arm that Dr. Karen Knight, the red-haired physician, what she was in charge of. And so what's an open label placebo? It's a placebo that everybody knows is inert, is a placebo. So there's no lying. It's not like, here, take this medicine. And this study was an injection, and Dr. Knight said, this injection has salt water. There is nothing in this injection that could physically help your back. But just the fact of being here, meeting with me, getting into the patient's gown, being in a hospital, getting an injection, those can automatically trigger your body's natural healing responses. Even though you know it's a placebo, this can still work. It's a crazy idea, and it worked. What we found is that people had a significant reduction in pain. I'm working on the data, the analysis right now. We're seeing benefits for even 1 year after. It was a single visit, one injection, one time in the hospital, and 1 year later, people are reporting less depression, less anxiety, and other positive benefits, and changes in the brain as well. Decreased activity in the thalamus, more activity in the ventral medial prefrontal cortex. So it's this like amazing take on it that even if you know it's a placebo, like even if you're doing dry needling and you think this is a placebo, that's wonderful, embrace it. But, you can, like, if you be like, this can work, but this treating your brain through the body is kind of treating your brain.
And what Yoni's talking about is, on average, there was a decrease in pain, but there were some people who had complete elimination of pain after that placebo injection. And they came back and said, can I get another injection? My pain totally went away. And so the placebo effect is very variable. It's not like a certain amount in all people. And some people can have zero effect. Some people get worse when you give them a placebo injection, because the injection is being interpreted by their brain as an assault, sticking a needle in them. That's why a lot of times people have surgery or injections and they get worse. And then some people have a dramatic response where the pain completely goes away. And then we know that that's the brain. It helps us in our diagnosis.
Like, I think what Howard's also getting to is just that placebo has a negative connotation, like, oh, it's just placebo, but really the placebo is, you are the placebo. It's the power of your mind and your brain, and we should celebrate and elevate the placebo.
Exactly.
Like a placebo national day.
Yes, we'll have marches
and pills, and okay.
No one's going to show up. They're going to think it's fake. And
only us, only the 134 people that are here. Okay, so next question is for Laurie. What were your initial expectations for in the beginning of the movie, and were you surprised by the results, or something?
Yeah.
Or Alan made a believer also, not only from Yoni, but also from you. Yeah.
I love the question. I've had back pain since I was 15. And so I had back pain coming into working on this project. And I was really holding tight to what I was told where that pain was coming from, which was a herniated disc in my lumbar spine. And it had been so debilitating for so long that part of the reason I was interested in working both on the study and the film was maybe there's another way. That being said, I didn't respond well to, I think, anyone, maybe, I remember like Alan and I ended up forming a pretty deep friendship because I was the one setting up the camera in the therapy rooms and, you know, doing a lot of the coordination. And I remember him telling, when he asked me where he thought my pain was coming from, I said, inflammation. And he said, you're smarter than that. And I remembered getting so defensive about that because we had more of this kind of like dynamic of friends rather than like maybe patient client, you know, client or anything a little bit more like subtle. So at first, the whole concept, I was kind of like, it's not for me, but it's pretty miraculous to see these people making these recoveries. And I think for me, the actually what helped me the most was watching hours and hours of the footage, because it was less personal. It was less like, I'm going to tell you about your pain. And it was more like, I'm going to watch Greg get out of pain. I'm going to watch Lindsay get out of pain. I'm going to see Abby, like the way that these other people were responding so beautifully to the concept that their pain could be coming from their brain. And I was kind of like, what makes me so special? You know, so I got softened, I think, through the process of making the film, actually, and all of the hours and hours and hours of footage that went on the cutting room floor. There was a lot to watch from these therapy sessions. And I was doing a lot of the, like, you know, just reviewing of that footage. So what I believe, I think, is much more nuanced now. I don't know if I would show up to the placebo day for sure. And I would probably carry a flag, but I still have pain that comes and goes that I am not, I'm still working through it. I'm in process.
I think in process could be the t-shirt we're going to hand out in this celebration on the placebo day. There's a question, what happened to the football player? Question mark. Shout out to Tim Kaminsky, who is the third director, because 2 wasn't enough. And he actually just got coffee with Greg a few weeks ago. And Greg, his journey kind of it was a bit of a roller coaster after the film, because he was out of pain after going through PRT, but then got in like a horrible motorcycle accident. And actually a lot of the principles he learned through the study helped him through that process as well. But he's doing much better now, and his dad bod is still, you know, pretty not a dad bod, I would say. Hey, great. I get a lot of questions about protocols. We love protocols. We love this manuals and protocols. So is there, I think it's more a question for Yoni, a specific protocol for PRT, for back pain, for fibromyalgia, or maybe something else?
We're running a clinical trial right now, and it's comparing PRT to CBT, cognitive behavioral therapy, which has been the most studied psychological treatment for pain, is widely implemented, at least in the US. And this study has really forced us to address this question, because if you're saying, okay, with, you know, PRT versus CBT, well, how do you draw the boundary, and how are they similar and different? Because there are areas of overlap, because they both talk about the influence of thoughts and emotions on pain, and they both try to get people moving again. So this has been something we've been wrestling with. And then on the other side, you have other treatments like that are very similar to PRT in many ways, like emotional awareness and expression therapy, or cognitive functional therapy, pain, like explained pain, Mosley Butler. There's a lot out there. And so it just feels like challenging and hard to draw the boundaries. And we have a bit of a protocol we developed for use in this study that, you know, I hope it's going to be continuing to evolve. I prefer to think about it in terms of key principles rather than protocols. Key principles and main techniques. So some of the key principles are you can assess people and determine that this is neuroplastic pain. A key principle is that neuroplastic pain is driven by a threat or the 6 Fs or that kind of response to it. And some of the main techniques that we use are somatic tracking, getting people moving again, evidence lists for and against. So I'm putting a link in the chat now for a website that has a training program. And is it oviddx.com, Howard? Is that the one? Oh, whoops.
I'll put a couple others there as well.
Howard's going to put a couple others too, where people can get training in this approach. But it's more of a principles and techniques than like a protocol. Like session 1 is this, session 2 is this.
I think the beautiful thing what Yoni is talking about is that, and we feel the same way for emotional awareness and expression therapy, Mark Limley and I, is that there's key principles that help people to lower danger, key principles to help them deal with trauma, to deal with stress. And even though this was a PRT study, the paper that was just published that Yoni and Hallie Tonka worked on showed that people made links between emotions and stress in their life as part of this study. And that was one of the 3 major, Yoni can probably talk about this more, one of the 3 major components of how people felt that they got better when they interviewed the patients, which was a really amazing study that just came out. But if you stick to principles, the techniques are going to evolve over time. People are going to continue to add different nuances and different ways of doing somatic tracking, different ways of doing graded exposure, different ways of doing what I call neurocircuit testing or provocative testing, all these different techniques that feed into the principles of lowering the danger signal in the brain.
So an immediate follow-up question is about a conflict, I think, that many therapists encounter during their sessions. And what about patients who want to get rid of the pain, but also want the acknowledgement, the recognition for their suffering? Is it goes into the same direction? Does one count for another? How do you work with that? I think it's for Dr. Schubiner.
Well, when there's one key factor that you have to start every patient encounter with, and it's a 4-letter word, okay? Love. You have to start with love, okay? And I didn't say this 20 years ago, but now I've come to realize that that's the most important ingredient, because if you don't love your patient, if they don't know that you love them and care about them and hear them and listen to them and understand their suffering, why would they listen to you in the first place? They wouldn't. Very few people have ever had a chance to tell their story and to have somebody listen, a medical professional listen to their story. And that's what we're starting with. And so the validation comes first. After validation, after listening, after understanding, then we can we can explore together to look at what is the evidence for what's going on, what's the truth here. And when you're on the same page with your client or patient, you're working together in what I call shared discovery, then you're going to get to the right answers most of the time.
So the first step is I see you, and the second step is let's work on it. Okay, the next question, I get a lot of questions about training in Israel, just young FYI, for pain reprocessing therapy. Yeah, many questions. Will there be like a certificate in Israel? So
it's international. We have people joining those trainings from all over the world.
So I highly recommend. I will be I'm registering for the next class, so you expect me there.
Yeah.
So in Israel, we have a small community that keeps on growing, that combines TMS, Dr. Schubiner's mind-body medicine work, and pain reprocessing therapy. Okay, I'm gonna speak a bit louder. We have a small community, TMS, PRT, mind-body medicine, and we keep on expanding. I think you will hear from us in the next couple of months. And you can try me, you can try Tova, I see here, Amir, Tivoni, I see Lihi. There are a lot of people working together, and we're constantly thinking about how to create this local community that works with the concepts you just saw on the movie and you hear from Dr. Schubiner, Yoni. Tova, do you want to say?
Yeah, there was, after I took the course last year, the pain reprocessing therapy, there was some talk about translating the course into Hebrew and would it be accepted? And I was talking with, Alan and his team, and, it'd be a lot to translate the course into Hebrew, but I think if there was a desire and an interest, they also wanted to translate the book, The Way Out, in Hebrew. And we spoke to the doctor from Focus who published Nir Brosh's book. And it really comes down to money, to kesef. And I think if there's an interest here, we can not only give the course in Hebrew, but in English, but we could maybe have it translating subtitles again and make it happen and share this incredible knowledge. So I think maybe we'll ask about the interest, and then I'd love to work on bringing the course. It's an amazing course, the pain reprocessing therapy. It's in English, and there was an interest. It's in Spanish now, and there was an interest to bring it in Hebrew. So we can see about the interest. It would be amazing, and I would be thrilled to be involved with that.
Yeah, and Tova, I see a question from Jenny. Will the movie be screened publicly? Maybe
yes, it was accepted by the Spirit Cinema Festival in I think October. It's going to be shown, and I think we could have more showings like this as well.
Yeah, which means that Mitch and Laurie will need to come to Israel and eat some hummus and
you can all stay with me.
So that will be a lot of fun. So the Spirit Festival used to be named.
It's in the Tel Aviv. It's in the Cinematheque.
Yeah,
I'll be advertising it.
Sure. So keep in touch. Okay. So another question about working with patients who has actually structural pain, structural injury. I think the concept, but they have imaged MRI or CT and have structural pain. And do you work with them with pain reprocessing therapy? Does it work? So Yoni and Howard, yeah.
Howard says no. I shake he doesn't take the blowback. I think my first thought when I hear that is curiosity about the diagnosis, and like it can be so difficult to know. And like Laurie's personal story is a great example. Like what is what is the driver of the pain? And so that's the first thought. And then PRT in its pure strongest form is not appropriate in the sense of there's nothing wrong with your body, this is your brain. You wouldn't do that, but you can adapt and modify to say, okay, the pain threat cycle is a big part of what's going on, and let's try to bring down that threat level and turn down the volume. And so a lot of the things can be adapted or modified for this kind of mixed pain condition.
Yeah, you can use a combination of medical therapies and mind-body therapies. Of course, you can do that. And that's been done. That's what's being done. That's the standard model of pain management therapy all around the world. Mayo Clinic, Cleveland Clinic, Stanford, et cetera, et cetera. We'll do a little bit of everything, a little acupuncture, a little PT, a little medication, a little massage, a little injection, a little adjustment, and mind-body work. Yeah, of course you can do all that. And that can be very effective for a lot of people. And it's especially geared toward when there is a combination of structural pain and mind neuroplastic condition involved as well. But as Yoni said, as I said, I guess, and Yoni said, you need to investigate carefully. And what I said is that the vast majority of people with chronic pain do not have a structural condition. And so a lot of times people are told they have a structural condition. And when you investigate it carefully using what I would call the fit criteria and provocative testing and gathering evidence over time, you will find most of the time, like only roughly 90% of the time, based on our studies, that it will be a neuroplastic pain condition and not a structural condition, even though the MRI may be abnormal, because the MRI is abnormal in all people who, are human basically and get a little bit older.
Yeah, wrinkles from the inside, right?
Exactly.
So, Dr. Schubiner, you wrote 2 books, Unlearn Your Pain and Unlearn Your Anxiety and Depression. So, what I want to ask you is, what is the connection between chronic pain and anxiety, and how can mind-body medicine or pain reprocessing therapy, even though it has the word pain in it, can do in even emotional cases? Yeah.
Yeah, well, what happened is that 20 years ago, I started working with pain, and I saw that some people, their pain went away and then they got horrible anxiety, or the anxiety went away and they got bad pain, or then they got depression, or then they got insomnia, or then they got fatigue. And I began to realize it was pretty obvious when you just pay attention that the brain has a number of mechanisms of ways to manifest a danger alarm signal. And again, to me, if we're looking for the root cause, if the root cause is danger alarm in the brain, and the manifestations may be anxiety or depression or pain or fatigue or long COVID or CRPS, et cetera, all the other ones that we see, and it's a vast array of these things, then we treat them all the same. So, if the brain is actually, it's funny, the brain will try to scare you, in a sense, alert you, its message. That lady I was saying about the burning feet, she had a tremendous fear of her feet. She was a ballet dancer, and her feet were the most important thing to her. Being able to walk and dance were the most important things to her. And so her brain chose to give her pain in her feet, and it scared the crap out of her. And that was just a danger alarm mechanism. It could have chosen to give her anxiety. The treatment is the same.
Okay, so we're approaching the end, unfortunately, because I'm having fun. So let's do like an open mic. Anyone who have a certain comment, question? I think my voice was heard. I talked a lot. I have my bottle of water. Maybe somebody from the crowd, from the audience, who wants to ask a direct questions or comment.
I ask that maybe you can treat that way in autonomic diseases, because it's very similar, the mechanism that the brain react to the brain see a threat in a neutral stimulus. So maybe you can educate the brain also in autonomic diseases in the same way.
מחלות אימיוניות.
לא, אוטונומיה של...
Autoimmune.
Autoimmune disease, yeah.
You mean autoimmune?
Autoimmune, sorry.
Autoimmune.
Autonomic, autoimmune.
There's been some amazing research from Israel recently from Asya Rolls, I think. She's either somewhere, the Technion or Haifa, that's really showing the influence of the brain and control of the brain on the immune system, which I think, really supports that possibility.
You didn't try it in the...
For autoimmune, no. I think, I don't know. Howard, what do you think?
Well, the brain, there's a field of psychoneuroimmunology. The brain can control the immune system. We know that. That's a fact. Now, whether doing mind-body work is going to cure all people with autoimmune disorders, I don't know. Certainly, there's much evidence on a case-by-case basis that some people have used mind-body work and have had dramatic results in their autoimmune disorders. Of course, you can always use medication and mind-body work together in autoimmune disorders. There's nothing stopping you from doing that as well. So I just take it on a case-by-case basis and see what people are interested in and see where it goes. If you read Gabor Mate material, he believes strongly that mind-body work can can have significant and dramatic effects in autoimmune disorders. And we know that autoimmune disorders are more likely to occur in people with childhood trauma.
Thank you.
Any other comment, question?
I have a question. How does this relate to a lot of work on the polyvagal system and all kinds of techniques that actually change your vagal tone, or all these different terms? Because it seems that it's very much connected to the threat response, or the 7 Fs or whatever. Can you comment on this a little bit?
Yeah, I know Stephen Porges. He's a great person. He's very smart. He's developed an amazing model for helping people. I'm not 100% sure that we can separate the vagus nerve from the brain. In my opinion, the brain actually controls the vagus nerve as it controls the whole autonomic nervous system. So sometimes if people think, well, I'm working on my vagus nerve, I think you're also working on the brain. Anyway, it's maybe a fine distinction, but the polyvagal theory has helped a lot of people. It's a great model for people understanding how to change, their nervous system. And we just think of it as the brain. They think of it as the nervous system, but I think the techniques are very similar and complementary.
Okay. That's what I was interested in, the different techniques, not whatever you're doing, but if these techniques can also be part of or helpful. And yeah, okay, thank you.
Sure, absolutely.
Yeah, so unfortunately, we need to finish our wonderful meeting, screening, discussion, and I want to thank all participants, Mitch, Laurie, Yoni, Howard, and every single one who came up. And I saw the discussion on the chat, which was really interesting. I couldn't really respond to it, but I see a lot of interest in this particular type of therapy and research. So stay tuned, because I think we have some interesting road ahead of us, and maybe we will do one more event like this. And just one final note, Mitch, we will, for those who weren't able to watch the entire movie, we will open a limited time, or like a free coupon to watch it later on. I will let everyone know in a very organized, well-informed mail. So thank you, everybody. I will share the recording, and that's it. Have a great weekend. Thank you for joining. It's 10 p.m. in Israel, so it's nice to see everybody still awake, and great to have you all. Thank you.
Thank you.
Thank you all so much.
Thank you, Laila Tov, to everyone in Israel. Thank you, Yoav, so much for organizing today. Yeah.
Thanks, everybody. Loved it.
Yes, this is great.
Thank you so much.